So this is a study that we started at MD Anderson close to 20 years ago, collecting samples when FCR was being established as the standard frontline therapy. MD Anderson ran a trial, the FCR 300. About the same time in Germany, they ran the CLL 8. And so one of the questions we were interested in approaching this was precisely, could we tell who was likely to actually benefit from this therapy? So we had collected samples along the way and went back and did a careful review of the clinical data so that we had reasonable information to get started. And we ran, this is a long time ago, Illumina microarrays to do the gene expression profiling to answer this question. And even though we had a relatively small number of samples, we could tell at MD Anderson, which the data were used for training, was that there were clearly 3 different outcome groups that we could identify based on gene expression signatures. One of them had extremely good responses to FCR. Many people, now that we have like 15 years of follow-up, still haven't relapsed. Then there were 2 other groups, one of which sort of had intermediate outcomes, another which had very bad outcomes. And when we looked at IGHV mutation status, the really good outcome group was mostly mutated cases. The 2 bad outcome groups were fairly evenly split between unmutated cases. So what we focused on at that point was, can we predict for new patients which one of the unmutated cases is more likely to respond well to FCR? And so we did some careful statistics to make sure that we got a robust predictor. So part of the point was that we had to make sure we had a robust signature because the CLL8 trial in Germany, they had assayed their samples with a different platform. So we had to make sure we had a robust signature that would go to another country, to another clinical data set, measured on a different platform. Statistically, we did this by doing a lot of bootstrapping and resampling with the initial data to make sure that we were getting consistent results throughout. And part of what we decided was that there were some samples that were hard to classify and some that were easy. And we decided to build the signature on the easy one, which is actually the different point of view from many statistical approaches previously, and I think it was an important step because we could clearly tell apart which ones were definitely going to do well and definitely going to do poorly, and we would get a gradation in between driven by the model instead of by trying to overfit the model. And we were able to validate this. The hazard ratio wasn't quite as strong in the German data, but it was still clearly strongly statistically significant. We could divide the samples into 2 different categories: the unmutated samples, the ones who would have fairly good prognosis, and the ones that would have bad prognosis.